Welcome back to the deep dive. Today, we are not just swimming in information, we are putting on the scrubs, walking past the nurse's station, and heading right into the deep end of the ICU.
Sounds serious.
It is. I have a stack of heavy hitters in front of me today. Miller's Anesthesia, Harrison's, Robbins Pathology, and, the absolute Bible Marino's ICU book. And I have to be honest with you, looking at this stack, I'm sweating a little bit.
Sweating.
Oh.
In the ICU, we usually keep the thermostat pretty low in there to keep the bacteria and the consultants from overheating. What is the source of the anxiety today?
The source is very specific. It's my upcoming MD anesthesiology exams. I've been reviewing the papers for Gujarat University, looking at the past trends, the patterns, and there's this one topic that is it's ubiquitous. It is everywhere.
Wow.
It's in the theory papers as a massive long question. It's in the short notes, and I just know I can feel it in my bones. It's waiting for me in the Viva Voce.
Let me take a wild guess. It is the bread and butter of the ICU, but it's also a physiological minefield. You are talking about the condition that breaks hearts and stiffens lungs. You're talking about ARDS.
Bingo. Acute respiratory distress syndrome. It feels like every time I open a textbook, the definition has shifted, or the ventilation strategy has been updated, or there's a new trial telling me everything I knew 5 years ago is wrong.
I see.
So my mission today, and your mission as my senior faculty mentor here, is to help me crack the ARDS code. I need the protocol. I need to get from a blank sheet of paper to a distinction level 20-mark answer.
I accept the challenge. And you are right to be hyper-focused on this. ARDS isn't just an exam favorite. It is a clinical reality that defines the career of an intensivist.
Right.
I mean, depending on which source you look at, intensive care is good for this.
Yeah.
ARDS makes up about 10% of all ICU admissions. And more importantly, it's nearly 23% of all ventilated patients.
Wow. 1 in 4.
So understanding this isn't just about passing the exam. It is quite literally about saving 1 in 4 of the patients you put on a ventilator.
That definitely puts the stakes in perspective. So let's unpack this. If I am sitting in that exam hall, the clock is ticking, and I see the question, describe the pathophysiology and management of ARDS. Where do I even start? Do I jump straight into the Berlin definition?
You could, but you'd be missing a trick, a really important one. Examiners love context.
Yeah.
They want to know that you understand the lineage of the diagnosis.
Okay.
Before you throw current definitions at them, show them you've read the big books. You need to frame the answer historically.
You mean going back to, the Vietnam War era? I remember seeing references to Da Nang lung.
Exactly. That's the high-level intro. Miller and the ICU book both discuss this. In the Vietnam War, medics became very good at fluid resuscitation. They were saving soldiers from hemorrhagic shock who previously would have died on the battlefield.
Right. They survived the initial trauma.
But then a few days later, these soldiers developed massive respiratory failure. They called it shock lung or Da Nang lung.
Okay.
It was the first time we realized that the lung could be a victim of a systemic insult.
So it wasn't a direct hit to the chest?
Not necessarily, but the real landmark moment, the date you want to drop in your introduction, is 1967.
That was Ashbaugh.
Ashbaugh and colleagues, University of Colorado. They described a case series of 12 patients. These patients had what they called refractory hypoxemia and stiff lungs. And the key finding was that they didn't respond to oxygen alone.
So just cranking up the oxygen didn't fix it?
Exactly. That paper was the birth of the concept. It sets the stage for your answer.
Right.
This is an inflammatory lung injury, not just heart failure.
Okay, so I open with 1967 Ashbaugh and the concept of refractory hypoxemia. That's my hook. Now, we have to deal with the definitions. This is where I get tripped up. I still see ALI or acute lung injury mentioned in older papers.
Nope.
But my residents tell me that's dead.
It is dead. Bury it. Writing ALI in a modern exam is a great way to signal to the examiner that you haven't read a paper since 2011.
Got it. No ALI.
We used to use the AECC definition from 1994, which had a category for acute lung injury for milder cases.
Yeah.
But it had problems. It relied on the pulmonary capillary wedge pressure, which is invasive, and, it's variable. So as of 2012, we operate strictly under the Berlin definition.
The Berlin definition. This is very high yield, correct?
Extremely. If you get a question on ARDS, you must reproduce the Berlin criteria table. It is non-negotiable. It has 4 main pillars. Think of them as the big 4.
Okay, let's walk through them. Pillar number 1.
Timing. ARDS is an acute process. The Berlin criteria are very specific here. The onset must be within 1 week of a known clinical insult or new worsening respiratory symptoms.
In 1 week. So if a patient has been breathless for 3 months and comes in with whiteout lungs, that's I don't know, interstitial lung disease or something else, but it's not ARDS.
Correct. The acute inflammatory nature is key. Pillar number 2 is chest imaging. You need to see bilateral opacities on a chest X-ray or CT scan.
Okay.
And the key qualifier here, which is straight out of the texts, is that these opacities cannot be fully explained by effusions, lobar collapse, or nodules. It has to look like edema.
Right, like fluid. Which brings us to the third pillar, the origin of edema. This is the non-cardiogenic part.
Precisely. You must rule out cardiac failure or fluid overload. The definition says respiratory failure not fully explained by cardiac failure. Now, here's a nuance for the exam.
Okay.
In the old days, you needed a wedge pressure less than 18. Berlin removed that. Now, if there is no clear risk factor, like the patient wasn't in a car crash and doesn't have obvious sepsis, you need an objective assessment.
Like an echo.
Exactly. You need an echocardiography to exclude hydrostatic edema. In the exam, if you write rule out cardiac failure, add via echo if risk factor absent.
Yeah.
It shows precision.
Right. Timing, imaging, origin. The fourth one is the big one, oxygenation, the PaO2-FiO2 ratio.
The PF ratio. This is how we grade severity now. But there is a very specific caveat that students forget and examiners love to trap them on.
Uh-oh.
This ratio is only valid with a minimum PEEP, a positive and expiratory pressure, of 5 centimeter H2O.
Ah, so I can't just take a room air gas? Or on a simple face mask?
No, because on 0 PEEP, atelectasis might make the ratio look worse than it is. They must be on at least 5 of PEEP to standardize the measurement.
Okay, that's a key detail.
And here is your severity grading, which replaces the old ALI categories. Mild ARDS is a PF ratio between 200 and 300. Moderate ARDS is between 100 and 200.
Yeah.
And severe ARDS is less than 100.
Need to memorize those cutoffs, 300, 200, 100. And mild ARDS covers that gap where ALI used to be.
Exactly. And this isn't just academic categorization. The mortality climbs with each step. We're talking about roughly 27% mortality for mild, 32% for moderate, and up to 45% or even higher for severe.
So when you grade the severity in your exam answer, you are also implicitly stating the prognosis.
You're showing the examiner you understand the clinical relevance. It's a big deal.
Okay, so we've defined it. We've graded it. Now, the examiner asks for the etiology. I usually just list sepsis and pneumonia and hope for the best. Is that enough?
It's passable, but we're aiming for distinction, right?
Right.
To get the distinction, you should classify them mechanistically. Divide your causes into direct lung injury and indirect lung injury.
Okay, that's a better structure. So direct being things that actually hit the lung tissue itself, the primary insult is pulmonary.
Correct. Pneumonia, viral, bacterial, fungal is the #1 cause globally. Aspiration of gastric contents is another huge direct cause. Think of your Mendelssohn syndrome cases in obstetrics or emergency induction.
Yeah.
Pulmonary contusion and trauma. Inhalational injury like smoke or chemical burns.
And near drowning would fit here, too.
Yes, those are all direct. Now, for indirect, you're looking at systemic insults where the lung is an innocent bystander. The mediators travel to the lung via the blood.
So sepsis from a non-pulmonary source, like a urinary tract infection or peritonitis or a hot gallbladder?
Exactly.
Yeah.
Sepsis is the major indirect cause. Then you have severe trauma with shock. Even if the chest wasn't hit, the systemic inflammation hits the lungs.
Okay.
And here are 2 exam favorites you must mention. Acute pancreatitis and TRALI.
TRALI, transfusion-related acute lung injury.
You got it. And pancreatitis always surprises people. It feels so far away from the lungs.
It does.
It is, anatomically. But physiologically, it's a bomb. It releases massive amounts of enzymes like phospholipase A2 and cytokines into the bloodstream. They circulate to the pulmonary capillary bed and just wreak havoc. It's a classic indirect mechanism.
Okay, so we have the causes, direct and indirect. Now we get to the core of the exam question, the part where I usually get bogged down in the cellular details. Pathophysiology. Robbins talks about diffuse alveolar damage.
Dead. That is the hallmark pathologic finding. If you were to biopsy the lung of an ARDS patient, that is what the pathologist sees. But don't just write dead. Break it down chronologically.
Okay.
If you're writing a long answer, structure it into the 3 phases. It gives your answer a narrative flow.
Phase 1 is the exudative phase, right? That's the start.
Right. Days 1 to 7. This is the storm. An insult, either direct or indirect, triggers a massive inflammatory response. Neutrophils get sequestered in the pulmonary capillaries.
So they get stuck in the lung vessels.
So you shouldn't be stopping there, but they get sticky. They release cytokines IL-1, IL-8, TNF-alpha. These are the bad guys in this story. They chew up the alveolar capillary barrier.
So the barrier between the blood and the air sac just breaks down.
It gets leaky. Normally that barrier is tight, Now, it's a sieve. Protein-rich fluid floods from the blood into the alveoli. This is crucial. It's protein-rich, unlike the watery fluid of heart failure.
Right.
This fluid washes away surfactant. The type I pneumocytes, the cells that line the air sac, die, and this proteinaceous debris mixes with dead cells to form.
Hyaline membranes. I need to underline that in my exam paper. That's the buzzword.
Absolutely. If you don't mention hyaline membranes, you haven't described ARDS pathology.
Yeah.
Now, physiologically, what does this fluid-filled alveolus do? It creates a shunt.
A shunt.
Blood goes past the alveolus, but because the air sac is full of fluid, it doesn't pick up oxygen. That gives you the VQ mismatch of 0. That is why you have refractory hypoxemia.
So no matter how much oxygen you give.
It won't work. If the unit is flooded, it won't participate in gas exchange. It's like driving a truck past a loading dock that's underwater. You can't load the cargo.
That's a great analogy. Okay, that's the first week. Then comes the proliferative phase.
Days 7 to 21. The body tries to heal. The type 2 pneumocytes, the survivors, start proliferating. They are the stem cells of the lung. They try to cover the denuded basement membrane.
So they're trying to patch things up.
They are. But at the same time, fibroblasts start migrating in and laying down collagen. The lung is trying to repair, but in doing so, it's becoming stiff. Compliance is dropping further.
And if it doesn't resolve, if the inflammation continues,
you enter the fibrotic phase. This is after 3 weeks. You get extensive fibrosis. The lung architecture is destroyed. On CT, you see a honeycomb appearance. This is where you get long-term morbidity. The lung becomes a scarred, stiff sponge that can't expand.
So exudative, which is fluid and hyaline membranes, proliferative, repair and stiffness, and fibrotic, scarring. That's a solid structure for the answer.
It is. And don't forget to summarize the 3 physiological consequences. Shunt, which causes the hypoxemia, decreased compliance, which is the stiff lungs, and increased dead space from microvascular thrombosis.
Right. Stiff, wet, shunty lungs. That brings us to the bedside, the clinical features. I assume the patient looks like they're running a marathon in bed.
Profound dyspnea. Tachypnea, increased work of breathing. You'll see central cyanosis.
And on the stethoscope.
You hear diffuse, coarse crackles rails. But the defining clinical feature, the thing that alerts you as the resident on call, is that you put them on 100% oxygen and the saturation barely budges.
That's the refractory hypoxemia we talked about.
That's it in action.
Now let's talk about investigations. We've got the patient, we suspect ARDS, we draw an ABG. What are we seeing?
Initially, respiratory alkalosis.
Is there panting?
Exactly. They are tachypneic, blowing off CO2 to drive their respiratory rate, but they are hypoxic. As they tire out, or as the dead space increases, meaning they are moving air but not exchanging gas, the CO2 starts to rise.
When the pH drops?
The pH drops, and you develop respiratory acidosis. You'll also often see a metabolic acidosis if there's sepsis or shock involved, lactic acidosis, and of course a widened A gradient.
And the imaging. You mentioned the X-ray shows bilateral opacities. What about the CT scan? This is where I've heard the term baby lung.
Yes. This is a crucial concept, popularized by Luciano Gattinoni. It changed how we think about ARDS.
How so?
In the old days, we thought the whole lung was stiff, homogeneously stiff. But the CT scan shows ARDS is heterogeneous.
Yeah.
It's not uniform. You have dense consolidation in the dependent areas, the back of the lungs if the patient is supine, because gravity pulls the heavy edema down.
So the back is wet and collapsed.
And the ventral part, the front, is aerated. It's essentially a small functional lung sitting on top of a consolidated lung. The functional volume is the size of a baby's lung.
Ah, okay.
This concept is vital because it explains why our old ventilation strategies killed people. We were trying to push an adult volume into a baby-sized lung.
The ventilation strategy makes so much more sense. Before we get there, though, post-CS lung ultrasound, is that worth mentioning in an exam?
Absolutely. It's becoming standard of care. You're looking for B-lines, those vertical comet tails that signify interstitial fluid. You'll see a thickened pleural line.
Okay.
And importantly, to distinguish it from heart failure, you look for spared areas or skip lesions.
Right.
ARDS is patchy. If you see uniform B-lines everywhere with a smooth pleural line, think heart failure. If it's patchy with a ragged pleural line, think ARDS.
Nice differentiator. Okay, let's get to the main event, management. My consultants always say there is no drug for ARDS.
They are mostly right. We do not cure ARDS. We support the patient while the lung heals. The management principles form a triad.
A triad, okay.
First, treat the underlying cause. Antibiotics for pneumonia, source control for sepsis, you know the drill. Second, supportive care, nutrition, hemodynamics. And third, the big one, lung protective ventilation.
This is the 20-mark jackpot. The ventilation strategy. This is where I get confused between volumes and pressures. Walk me through the ARDS net protocol.
Okay. This is the gold standard.
Yeah.
In 2000, the ARDS net trial changed everything. Before that, we gave big breaths, 10 to 12 millirel kilograms. We thought big breaths open the lungs and normalized blood gases.
And that killed people.
Because trauma. We're over-distending that tiny baby lung, ripping the alveoli apart.
Sure.
So the protocol is low tidal volume, target 4 to 8 millilocule, but usually start at 6 millilocule.
Wait, 6 millilograms of what weight?
Predicted body weight, PBW.
Yeah.
This is the biggest Viva trap. Do not use actual body weight.
Right.
If you have a 150-kilogram obese patient, their lungs are not 150-kilogram lungs. Their lungs are the size of their height. You calculate PBW based on height and gender.
I'll make a note. Do not ventilate the fat. Use the height.
Crucial. So low tidal volume prevents volley trauma. Next, plateau pressure. P-plat. You want to keep this less than 30 centimeter H2O. This prevents barotrauma.
So volume less than 8, usually 6 millokg, PBW, pressure less than 30. What about PEEP?
PEEP is vital. You use PEEP to recruit those collapsed alveoli in the dependent regions and keep them open. This prevents atelective trauma.
Atelective trauma.
It's the sheer stress caused by alveoli snapping open and shutting with every breath. It's like bending a paperclip back and forth until it breaks. PEEP splints them open. We typically use a high PEEP strategy, titrating based on the tables from the alveoli trial.
But if I use small volumes and high PEEP, won't the CO2 go up?
It will, and we accept that. That is called permissive hypercapnia. We allow the pH to drop as low as 7.20 or even 7.15, as long as we are protecting the lung from high pressures.
Better sour than stiff.
Exactly. The acidosis is rarely fatal. The lung injury is. Unless they've raised intracranial pressure where CO2 would dilate cerebral vessels and cause herniation, we let the CO2 rise. Okay. There's one more pressure value you should mention for bonus points. Driving pressure.
That's plateau minus PEEP.
Yes. Amato and his colleagues showed that keeping driving pressure less than 15 centimeter H2O is the strongest predictor of survival. It basically tells you how compliant that baby lung actually is.
So it's a measure of the strain on the lung.
Exactly. If your driving pressure is high, you are overstressing the available lung units.
Okay, so I've got my ventilator settings. 6 millokg, PBW, P-plat less than 30, driving pressure less than 15, high PEEP, permissive hypercapnia, and keeping FiO2 just enough to keep SpO2 88-95%. We don't need 100%.
Correct. Oxygen toxicity is real. Free radicals damage the lung further.
What if that fails? What if the patient is still hypoxic despite optimal ventilation? We move to adjunctive strategies.
The first-line rescue is prone positioning.
Flipping them on their stomach. I've seen the nurses do this. It's a massive operation.
It is, but the Permissive trial showed a massive mortality benefit, significantly dropping the death rate in severe ARDS. You prone them for at least 12 to 16 hours a day.
Why does it work? Is it just gravity draining the fluid?
That's part of it, but it's actually more elegant physiology. When a patient is supine, the heart sits on top of the left lung, compressing it. The abdominal contents push up the diaphragm, squashing the lower lobes.
Right.
When you flip them prone, the heart falls forward onto the sternum, unweighting the lung. The abdomen is supported, freeing the diaphragm. But most importantly, it recruits the dorsal lung segments.
The back of the lungs.
Right. And nature has designed us so that the majority of pulmonary blood flow goes to the back of the lungs. So when you open the back of the lungs, you match the V, ventilation, to the Q, perfusion.
It makes the VQ more homogeneous.
You got it. It distributes the strain of the ventilator more evenly.
Okay.
It's brilliant.
That is brilliant. And neuromuscular blockade. Paralytics.
The ACURASYS trial suggested using cisatracurium for the first 48 hours in severe ARDS. It prevents patient ventilator dysynchrony fighting the vent and reduces oxygen consumption. It's worth mentioning, though newer studies like the ROSE trial suggest using it only if needed, not routinely for everyone. But for the exam, listing neuromuscular blockade in early severe ARDS is correct.
What about fluids? Do we run them wet or dry?
Dry. The FACTT trial compared conservative versus liberal fluid strategies. A conservative strategy, keeping them in negative balance once shock resolves, improved lung function and got them off the ventilator faster.
Makes sense. Wet lungs don't exchange gas. You want to wring them out.
Exactly.
Okay.
Yeah.
Prone, paralysis, dry. Now, the pharmacological section, my residents always ask about steroids. It seems like every few years steroids are in or out.
Ah, the eternal debate. Steroids and ARDS. The consensus currently, and what you should write, is that methylprednisolone may be useful in early ARDS to dampen that cytokine storm.
Early.
But you must avoid it in the late fibrotic phase, after about 14 days, because it can actually increase mortality by inhibiting necessary repair. So early,
Maybe.
yes. Late, no. That's the safe answer.
And surfactant. It works for premature babies with RDS. Why not adults?
It failed in adults, multiple trials. The adult lung is too big, the delivery is too difficult, and the inflammatory sludge deactivates the surfactant you pour in. Do not suggest surfactant replacement for adult ARDS.
Got it. And inhaled nitric oxide.
It improves oxygenation temporarily by dilating vessels in the good parts of the lung, but it has no mortality benefit. It's a bridge, a rescue therapy, not a cure.
So it makes the numbers look better.
While you fix the underlying problem,
Right.
it doesn't save lives on its own.
Okay. Rescue only. We need to talk about complications. I imagine keeping someone on a ventilator with positive pressure for weeks causes issues.
We group these under ventilator-induced lung injury.
Right.
We talked about barotrauma pumping a lung, pneumothorax, volley trauma overstretching, atelectotrauma, that's shear stress.
Yeah.
But the scariest one, and the most conceptually interesting one, is biotrauma.
Biotrauma, what's that?
This is where the physical force on the lung causes the release of inflammatory mediators into the systemic circulation. So the ventilator effectively causes multi-organ failure. You injure the lung with the vent, the lung releases cytokines, and the kidney dies.
So lung protection is actually kidney protection.
Precisely. It is systemic protection. Other complications include VAP, ventilator-associated pneumonia, and long-term sequelae, like pulmonary fibrosis and ICU brain.
This leads us to prognosis. What are we telling the family?
Mortality is still high, 35% to 45% generally, though it varies by etiology. But interestingly, patients rarely die of refractory hypoxemia anymore. We are good at oxygenating now.
So what's the cause of death?
They die of MODS, multi-organ dysfunction syndrome, or sepsis. If they survive, their lung function usually recovers reasonably well, surprisingly so. But their quality of life can be impacted by muscle weakness and cognitive issues for years.
Okay, we're nearing the end of our protocol. I want to solidify the exam presentation. If I'm writing this 20-mark answer, I need diagrams. Text walls get low marks. What am I drawing?
Visuals get marks, absolutely. First, draw the Berlin definition table. It shows, the criteria cold.
Okay, a table.
Second, draw a pathophysiology flowchart. Insult leads to cytokine storm, leads to capillary leak, to edema, to DDO, simple boxes and arrows.
Easy now?
And third, draw the pressure volume curve.
The PV curve.
Yes. Draw the sigmoid curve of the lung, mark the lower inflection point. That's where the alveoli start to open. You set your PEEP above this, then mark the upper inflection point. That's where the lung is overdistended. You keep your PEEP plat below this. That single graph explains the whole lung protective strategy in one image.
That is gold. And finally, before we wrap up, what are the common exam traps or Viva bait I should avoid?
1. The weight trap. Never use actual body weight for tidal volume. Always predicted body weight.
Yeah.
If you say 6 milliliter/kilogram without specifying PBW, I will fail you.
Okay, VW always.
2. The cure trap. Don't list drugs as the primary treatment. The treatment is ventilation. 3. The HF trap. Failing to distinguish heart failure from ARDS. Mention the echo, the fluid status. And 4. The recruitment trap. Recruitment maneuvers, blasting high pressure are risky. Mention them with caution, noting they can cause hemodynamic collapse.
This has been incredible. I feel like I have a roadmap now. Let me try to summarize the elevator pitch for the exam answer.
Go for it.
Okay. ARDS is non-cardiogenic pulmonary edema defined by the Berlin criteria. Timing, imaging, origin, oxygenation. Pathologically, it's diffuse alveolar damage, or DAD, driven with cytokine storm.
Good.
Management focuses on treating the cause and lung protective ventilation. Low tidal volume, like 6 millokg, PBW, P-plat under 30, high PEEP, and permissive hypercapnia. Adjuncts like prone positioning save lives in severe cases. And the goal is to prevent villi and MODS.
You nailed it. If you write that structured definition, pathophysiology, investigations, management, with a focus on ventilation and adjuncts, you're looking at a distinction-level answer.
I feel much better about facing the examiners now. Thank you so much for walking me through this.
You're welcome. Just remember, in the exam and in the ICU, treat the lung like a baby lung. Be gentle.
I'll check the show notes for the Berlin table and that PV curve diagram we discussed.
And here's a final thought to chew on. We've spent 50 years perfecting the ventilator to stop injuring the lung. We've become experts at damage control. But will we ever find a drug that stops the cytokine storm before the lung gets wet in the first place? Or is the mechanical ventilator always going to be our only real tool?
Something to think about. Thanks for listening to the deep dive. Good luck with your exams.